Good afternoon and welcome to Baptist Health International's quarterly medical lecture. I am Dr. Galit Hakim, Assistant Vice President of International Healthcare Partnerships and Insurance Development at Baptist Health International. It is my pleasure to welcome all of you to this informative presentation. I would like to extend warm greetings to our friends across Latin America, the Caribbean, and everyone joining us today. During this interactive presentation, you'll have the ability to ask questions via the Q&A feature located on the bottom of your screen. I will be your moderator in today's lecture. This afternoon, I have the distinct pleasure of introducing Dr. Herberto Valdes, who will be presenting a lecture titled Testosterone Replacement Therapy in Male Hypogonadism. Dr. Valdes is a board-certified endocrinologist at Baptist Health, South Florida. He treats patients with hormone-related diseases such as diabetes and thyroid disorders. Dr. Valdes is passionate about endocrinology because it allows him to play a critical role in the lives of his patients. Through lifestyle modification and innovative therapies, he helps patients prevent potentially life-altering conditions. Dr. Valdes joined Baptist Health South Florida from the Broward Health in Fort Lauderdale. In addition to treating patients, Dr. Valdes is an assistant professor of medicine at the University of Central Florida College of Medicine. He has also participated in several endocrinology clinical trials, led presentations for the Endocrine Society and American College of Physicians. His philosophy to patient care is always to prioritize the needs of the patients first. This philosophy has allowed him to provide compassionate care without compromising treatment excellence. When he's not treating patients, Dr. Valdes enjoys a variety of outdoor activities and stays as active as possible. Please let's give a warm welcome to Dr. Herberto Valdes. Thank you, Dr. Valdes, for joining us today. The floor is yours.
Thank you, Dr. Hakim. A pleasure. Dr. Hakim, today I will be talking about hypogonadism in the aging males. First of all, I would like to start the presentation with a very basic definition of what hypogonadism is. And basically, is as simple as diminished functional activity of the gonads. Now, some of the most simple pathophysiology of hypogonadism in the aging male is basically that as we get older, especially after 35 years of age, we start to notice a decline in testosterone, which is actually more pronounced after 80 years of age. With age, we notice that sex hormone binding globulin start to go, and also free testosterone tends to decrease. There is also an increase in certain gonadotropins as well as FSH and LH, although not as expected for the drop in testosterone, which make us suspect that there is actually a component of primary and also secondary hypogonadism as we get older. Now, I would like to start by talking about some conditions that are really common in the elderly patients that are actually associated with hypogonadism. Those common conditions, this patient population include COPD, end-stage renal disease, obesity, obstructive sleep apnea, and also some common medications like opioids or glucocorticoids.
Dr. Valdes, before you continue, if I may interrupt, are you about to put the presentation up? It's
yes.
Not being projected.
Oh, sorry.
No problem. I still thought that you were given the intro, and it sounded perfect.
Okay. Hey, are you able to see it now?
Not yet.
Not yet. Okay.
Now we can.
Now you can. Okay.
Yeah.
Perfect. Well, the most important, one of the most important things when we talk about hypogonadism in patients is, first of all, to diagnose hypogonadism, right? Now, we need to have two things. Number one is symptoms of hypogonadism, and number two is definitely some evidence of low testosterone levels. Now, the way I think about diagnosis of hypogonadism, especially in the elderly patient, is that it's mostly a clinical diagnosis, which we actually supplement with lab data. Now, some of the most common symptoms that I personally encounter in my practice that patients complain about when they are suspecting hypogonadism or they want to have more testing to to see if this is what is happening with them. Is number one is fatigue. Is that I would say this the most common symptom. At the same time, fatigue is a symptom that is very non-specific, so we always have to rule out other possible causes as well. Number two is decreased libido and depressive mood. Now, for us to proceed with testing, we start with as simple as a total testosterone. This is something that we try to do fasting early in the morning. This is something that we don't do in the hospital. It's definitely not doing any acute illness, since this can affect the results. Now, once we obtain this first testosterone, if we come back low, then we always try to repeat it for a second time to confirm. And in that occasion, we'll include all the labs like LH, FSH, prolactin, right? Now, there are some situations when we have this patient that have the symptoms suggestive of hypogonadism, but testosterone levels, they come back borderline, right? So in this patient, we suspect any alteration in the sex hormone binding globulin, then what we're gonna do is we're gonna check for free testosterone. Now, that's something that can be done through equilibrium dialysis, or it can actually be calculated as well. So those are the best two methods. Now, here I list some conditions that can actually increase sex hormone binding globulin, as well as some conditions that can lead to a decrease of sex hormone binding globulin. So in patients, whenever we see this picture, we always have to keep this in mind, right? Now, once we have the symptoms and the lab showing that there is definitely a decrease in testosterone levels, then the next question before we treat patient is to find out if there will be a benefit, first of all, right? If therapy will be beneficial for this patient, also making sure that there is no any a possible side effect or contraindication. So for that, there is a study that was done. Is mainly seven different placebo-controlled studies. These studies were done to evaluate if raising testosterone levels in men had any benefit. These are known as the testosterone trials. They were done in men above 65 years of age with low testosterone and symptoms. And basically what they looked at was if testosterone would provide to these patients an improvement in sexual function, physical function, vitality, cognitive function, anemia, bone density, and also cardiovascular risk factors. Testosterone trials basically concluded that yes, there is actually a moderate improvement with testosterone replacement in this patient when we, in regards to the sexual activity and desire. They noticed improvement in that. They also noticed that there was an improvement in the walking distance of this patient, in the mood, unexplained anemia, as well as bone mineral density. Now, they also found in this study that testosterone didn't have any effect on the vitality of cognitive function of these patients, and there was actually an increase in non-calcified coronary artery plaques volume. So that's basically the main findings they had in these testosterone trials. So once we identify this patient with low testosterone, that we are pretty certain this therapy, testosterone replace, will help them in these with these points we just discussed. We also have to make sure there is no contraindications. Now, in general, the most common contraindications for testosterone replacement are untreated prostate cancer. Now, pay attention, this is only untreated. It's not really, sometimes patients when they have a prostate cancer but has been treated, in some situations you can treat them with testosterone replacement. Now, hematocrit above 50, a patient with untreated severe sleep apnea, patient with severe lower urinary tract symptoms, and patient with uncontrolled CHF. Now, when we talk about cardiovascular health, prostate disease, and risk of thrombosis, the information or the data that we have is kind of controversial. Now, especially about cardiovascular health, we can go back to the testosterone trials. Basically, in this study, what they show is that there was no increased risk of cardiac events or prostate cancer in this patient. This study was kind of limited due to the sample size. So for this reason was not enough to draw a conclusion. Now, at the same time, we have other study, which was done at the VA hospital. It was done between 2005 to 2011. This was a retrospective study. And in this study, they actually found that there was some negative data suggesting a small increase in the risk of cardiovascular disease. These were patients with low testosterone who underwent coronary angiography. And they actually found that there was an association between testosterone therapy and the increased risk of adverse outcomes in this patient. So both studies, they were kind of, they had these controversies. Now, when once we have the patients that we know therapy gonna help them, that we at the same time know there's no any contraindication or any other risk, now the next step will be to select what is the best therapy for patient. That's something that is very unique for each patient. We have many different options, right, to choose from. Some of the most common are the transdermal formulations and also the intramuscular. Now, intramuscular is usually is one of the most common because it's easier for the patient to be compliant with the therapy. We usually start with 200 milligrams every 2 weeks. Now, at the same time, it's not so physiologic, so there is a high risk for possible side effects, especially with the peaks. And it's, the other good thing is that it's an inexpensive therapy. We have intramuscular formulations that are longer acting. Patients can have it every 10 weeks. This is usually given in office due to the risk of pulmonary oil microembolism and also the possible risk of anaphylaxis. Now, there are other forms of testosterone replacement like the pellets. They're usually placed every 4 to 6 months. It's a surgical procedure. So as with any surgical procedure, there is always a risk of infection, bleeding. Now there is a risk of overdosing because especially at the beginning, you kind of estimate how many pellets the patient gonna, how many pellets gonna be implanted in the patient. So sometimes that can lead to increased hemoglobin, and if you want to remove these pellets, it's something that have to be surgically done. Now, the other and the most common therapies, the one that provide that are more physiologic, is the gel, the patch, and the lotion, as I discussed before. They tend to give a relative steady serum concentrations of testosterone. They are easy to apply. Now, the precaution that we need to have with these formulations, especially with the gel, is to make sure that when patient apply, it's not in contact with his wife or with kids, right? So they don't get exposed to the testosterone. Now, with patch, a very common side effect is skin irritation. It's extremely common. I personally see a lot of patients that when they start the patch, they don't like it because of the irritation. They always most of the time they ask to change therapy because of that. Now, we have less commonly used formulations like the intranasal, oral. So we have many tools. It's just a matter of what the patient feels more comfortable using and also making sure there is no any possible side effect, right? Now, once we start therapy, the first thing that we have to make sure is that there is no any side effect to the testosterone replacement. For that, we're gonna keep an eye on testosterone levels, making sure they are therapeutic. We're also gonna keep an eye on the hematocrit, the PSA. We're gonna look and see if there is any improvement in symptoms, right? Because if we're gonna be giving the testosterone replacements to patients, we want to make sure they are obtaining something beneficial from it, right? That they are feeling better with the therapy. Now, usually patients the ones that are gonna notice more improvement are the ones that have the lowest levels, right? The lower the testosterone levels, once you start the therapy, the better you're gonna feel. Now, patients sometimes when they are borderline, they don't notice such a significant improvement in symptoms, but still it helps. Now, in male patients who present with osteoporosis, before we start testosterone therapy, we try to repeat the bone density at least a year after therapy to monitor if there is an improvement. We want to make sure that the patient has a sleep apnea that is being treated, especially if they are on testosterone replacement, because If they have a sleep apnea, they're being treated on testosterone replacement, and they discontinue the treatment for sleep apnea, they can actually increase hematocrit. Now, something else we're going to keep an eye on is on the PSA. If we see an increment in PSA of 1.4 within 12 months, that's an indication to stop therapy. And obviously, if the PSA is above 4, that will also be an indication to hold therapy and do some more investigation about this. So I guess it was a very fast presentation. I don't know if
we haven't received any questions just yet, Doctor, but this is one of those topics that nowadays it is much easier to actually digest and talk about. Hormonal replacement therapy has always been seen as perhaps a last resort, but not to every man that has suffered or has gone through the laundry list of symptoms that you mentioned earlier. Obviously, in the past 10 years, we have changed the ways we deal with the issues of testosterone. But aside from the pellets and the medications that you mentioned, are there other alternatives to increase the testosterone level in serum that will be similar to what the testosterone replacement therapy would do?
Yes, always what we want to measure is definitely if patient is overweight, losing weight, exercising, those are things that can help increase testosterone levels. If they have a history of a sleep apnea, definitely we want to treat that right before we start therapy, which can always help with the levels. So those are the most, definitely lifestyle changes are always play a critical role. And obesity is something that is so common, right, in our society, and it's something that if patient is able to lose weight, especially with exercise, can actually improve the levels as well.
So how do we manage, because obviously in men, one of the issues that we have is the estrogen level might be perhaps questionable. And how do you actually compensate in order for testosterone to take the ruling form of hormonal release in the body?
Right. Well, testosterone actually there is a high risk of increasing estrogen with a higher. That's usually when it's supratherapeutic dosages, right? That's something I will see more with injection, especially if they are taking a high dosage of testosterone. For that, it's something that we always gonna monitor, right? We're gonna try to keep the levels therapeutic, so there is no an excess of testosterone that is converted to estrogen and patient develops some of these symptoms, right? Like gynecomastia or things like that, right? That are more associated with a high estrogen.
Exactly. We have a question from the audience. It says, is there statistical data of outcomes? Does insurance cover this treatment? For an oncology patient, can these treatments be applied?
Definitely. Yes. For oncology patients, definitely. I believe the question is about more prostate cancer. Yes. Now, therapies are covered, especially if it's intramuscular. I think insurance, most of them pay for it. I don't think they will give, let's say, a hard time to the patient. Is mostly the other type of formulations when we're talking about different type of gels, right? Like androgel. It might be a little more difficult to get coverage depending of the insurance. But yes, at least intramuscular is definitely affordable and something that I personally have seen that most insurance cover. Now, about prostate cancer, if it's a patient that is currently with prostate cancer, you're definitely not going to treat. But if it's a patient that has surgery, went through all the therapy, there is no any evidence of metastases, right? Right, if they are stable, definitely therapy can be applied for sure. Now, in those patients, I wouldn't probably go with the intramuscular formulation. I will try to use more, as I said before, like the patch, gel, right? But yeah, as long as they are stable, there is no any evidence of metastasis or recurrence of the cancer, it can be used. Yes.
Right, and you're absolutely right. And as an insurance insurance is one of the hats that I wear at Baptist International. And I can tell you those therapies are covered, except that there are some exclusions in some policies. So you need to check with your actual insurance carrier for that. Now, in regards to the gel that you have mentioned or you've been mentioning, there are some cautionary tales behind the use of gel, and that has been somewhat in the news in regards to not to be careful not to touch other individuals, or can you elaborate a little bit more as of what kind of care does a patient that require the replacement through gel is in need of?
Yes. So usually the recommendations I give to patients, I always recommend to apply it after they take a shower, usually at night. So they can put it in the shoulders, and always to put a shirt on top of them. It's what I always try to tell them. Now it's important if they have babies at home, right? Not be carrying the baby after applying the gel, because there is always a chance that the baby can get exposed to the testosterone, right? But as long as they apply, and at least if they can put a shirt before going to bed, that will kind of decrease the chances of passing it to the significant other, right? Now, in those patients who that is a concern, for example, let's say patients who have a newborn at home, then we can consider other things like the patch, right? If they are interested in the transdermal formulation. But yeah, those will be the main recommendations I will give them.
So based on that argument alone, I will say it raises questions in regards to not necessarily the effectiveness of the testosterone replacement therapy, but more so of the potential side effects that this particular treatment can actually bring on to a man. Can you elaborate a little bit more on that?
Yeah, with the gel, because it's more physiologic, remember these are patients that are already deficient in testosterone, right? Now, for gel, you will have to give very high dosages, and really to go to super therapeutic dosages is kind of difficult. At least that's my personal experience. It's something that is more common with injections, as I mentioned before. Now, what happens is that the patient, the other family members that can be exposed to this patient, they maybe don't have hypogonadism, right? So there is always a higher chance for them to develop excess testosterone, especially if it's a female or a newborn, that for the patient itself who is from the beginning deficient in testosterone. But yeah, with the testosterone transdermal formulation is really difficult. At least that's my personal experience, to make a patient to have those levels above the target that we aiming for, right?
Mm-hmm. And how often does a patient need to monitor the testosterone levels? How often do you recommend they run laboratories?
Right. Usually, what I try to do is when I start them on therapy, depending what type of therapy I start them on, I try to see them back like in 2 months for the initial labs. I try to run all the labs. I get definitely these are labs that we did before starting therapy, right? We want to make sure the PSA is okay. We want to get a baseline hematocrit, right? We get a lipid profile, we get a CMP. But usually 2 months after they start therapy, I try to ask them to return to the office. We repeat labs to see how the testosterone levels are, to ask them if they have noticed any improvement in the symptoms. Sometimes it can take a little bit longer, right, for them to really notice an improvement. But at least you get kind of like a sense, an idea how they're doing, if the therapy is really working, making sure they don't have any side effects. Now, the longer the patient has been on the therapy and you have seen that labs are okay, there is no any side effect, the more relaxed you can, the more you can expand the intervals of follow.
Okay. We have a question from the audience. What about patients who have a low T level on a routine check, say 100 nanograms per deciliter, but asymptomatic, only overweight and 40 years old? Would this patient need T therapy, testosterone replacement therapy, or try to achieve ideal BMI? Will be the way to go.
Yeah, as I said before, I always the way I think about it is more is a clinical diagnosis supplemented by lab. And now 100 is low. What I recommend is if the patient is asymptomatic and the patient is really willing to lose all this weight, that's definitely the route I would choose. Now, what you want to do as well is you want to make sure the patient doesn't have osteopenia or osteoporosis due to the social load, testosterone levels, that they don't have any other problem due to the deficiency in testosterone. If that's the case, they may benefit a little bit more from testosterone. If no, and if the patient is asymptomatic, I believe with the modifications, right, and trying to lose weight will be a good option.
Okay. And when would you be concerned in regards to the level of testosterone? When do you say, as an endocrinologist, you need to start on testosterone replacement therapy? What is the threshold in your laboratories when you view them?
Yeah, when you start seeing them in the hundreds, like in 150, mid 100s, that's considered a kind of low. Now, in their labs, it's usually 275. It changes a little bit from lab to lab, but usually when patients are borderline, if they're asymptomatic, sometimes you don't have to start them, especially if they are not interested. But when you start seeing those levels kind of low, you always have to question yourself, what is the reason for such a low testosterone levels, right? That's why you want to also include FSH, LH, but you want to make sure there is no anything else like a central hypogonadism or something else that is contributing to this deficiency.
Mm-hmm. And in the case of the central hypogonadism, what is the route that you would take?
Right. If there is any evidence of a central hypogonadism, right, like pure central hypogonadism, that's something that we see very commonly with obesity, right? With obesity, kind of the pattern that you're gonna see is like a low testosterone with kind of low LH. So it's usually seen in these patients, but always you have to rule out that there is no any lesions, right, in the pituitary gland. So you're gonna get FSH, LH, as we discussed, but also you're gonna check prolactin, based on what it shows and the degree of suspicion that you have. Then you're gonna order some other tests, right? Maybe ferritin, right?
Right. In order for you to make certain that the diagnosis is not necessarily from the actual gland.
Correct.
Fernando is wondering if there is a patient with coronary heart disease and low testosterone level and symptoms due to low level of the hormone, what do you do? What do you do with replacement therapy or not? I'm sorry, I should have read it before, but in essence, if the patient has coronary heart disease and low testosterone level, what do you recommend in this particular patient?
Yes. The patient have coronary artery disease, as long as the patient doesn't have a heart failure, right? Like unstable heart failure. Depending on how bad the coronary artery disease is, I would definitely treat the patient. Now, I wouldn't use injections, but definitely gel, especially if the patient is symptomatic, I will treat it. Yeah, as long as the patient doesn't have heart failure, right? Like unstable.
Have you noticed any long-term treatment side effects? If you have your patient on a long-term type treatment, is there any risk to the patient's health for that matter? Or do you say, well, I'm going to evaluate you at this threshold in order for me to determine if I should continue treatment for you with testosterone replacement?
Right. So I haven't personally encountered any long-term complication from testosterone. Usually, if patients have any underlying issues, you will know pretty soon. There are some patients that tend to, when you start them on testosterone replacement, you're gonna see that their hematocrit goes up really, goes high, right? So patients have, we can say they're a little more sensitive, right, to these therapies. But those are things I personally usually have noticed that it's something that you detect earlier after therapy. Really long term, I haven't really encountered any any long-term complications, let's say that way.
Okay. Are these treatments long-term, meaning for life, or would this correct the actual issue?
No, these are maintenance therapies. So these are patients that have a hypogonadism, and basically you're supplementing exactly what they're missing, right? They are missing, they don't produce testosterone, so you basically give them what they're missing. Now, what happens is that it's actually the opposite. The longer these patients are on testosterone replacement, right, the less is the chance that they're gonna produce their own testosterone, right? Because there is a suppression. But yeah, so this will be long-term therapies, correct?
Do you stop and go? Do you give a period of holiday for the patient to actually be off the testosterone replacement to see if his organism is going to kick in to start producing testosterone?
No, that in older patients, once you start them on testosterone, is something that I personally never do. Now, what I have seen is some patients that have been on testosterone for any reason, they stop using the testosterone. And I can tell you something they don't like because of the symptoms, right? They can notice those symptoms immediately. For example, patients who are on injections because of hypogonadism, they're feeling fantastic. If they miss a couple of injections, they're gonna tell you, doctor, I need it. I'm not feeling.
I don't feel like I was feeling last week. Yes.
It will allow you to do a holiday.
That's right. So no holidays. Now, there are some treatments that have been noted to be also efficacious in increasing the testosterone. For instance, the use of clomiphene. For instance, how do you feel about that? What is your take in regards to this alternative type of treatment to increase testosterone and go through the backward feedback loop and skipping some components of the release of hormone?
Yeah. So what happened with clomid? I don't use any older population. It's something that I have done in younger patients, right? Especially when I feel something more like transient. And it definitely has to be central hypogonadism, right? As long as you rule out other possible causes. Now, what happens is that the main inhibitor for production of LH, FSH, right, gonadotropin is estrogen. So basically, that's what clomid does. Make your kind of brain feel that you have less estrogen, so they kind of stimulate the production of LH, FSH, and then eventually more testosterone, right? That's how it induces ovulation, kind of how it induces ovulation in females. So clomid I have used in this specific group of patients, and it's something that I do for a short period of time. But in older patients, not really. These patients, when they are 65 and above, I usually, right, I believe this is the best therapy, especially because
you switch them to the actual testosterone replacement therapy.
Yeah, especially because there are no, at this age, they are not looking for to have babies, right?
Yeah, it is more about bone density. It's more about feeling, again, alive, I suppose, and not feel depressed. And so the opposite to all the symptoms that your patients will manifest.
Correct.
Yeah. Any other thoughts before we conclude the webinar? Any other thoughts that come to mind in regards to why should men look into the levels of testosterone and when should they start looking into that?
Yeah. So after, I believe, as I say, after 35 years of age, we start having a decline in testosterone levels. But once they have the symptoms that we discussed before, it's always a good idea to have checked the levels. So especially after 65, is when I would recommend to, right after 65, you have symptoms like the ones we just described. It should be part of the evaluation, right? Especially like fatigue, definitely low libido, right?
To make sure that at least we are addressing those symptoms proactively and not have the patient go through those mood swings and then feel like, life is not what it used to be and focus on other energies. So definitely one of the things that we have learned in medicine is lifestyle modification is absolutely imperative. And as you mentioned, weight control and obviously the being all inclusive in regards to exercise and not limit ourselves as we age. As a matter of fact, it is more needed more than ever in order for our system to recuperate or mitigate some of the issues with hormone deficiencies.
Especially in patients with hypogonadism, sometimes when they are overweight, that you recommend exercise. One of the answers they have is, doctor, I want to exercise, but I feel so tired, right? And it may be because of the same deficiency in testosterone they have. So, yeah, so I think that, for example, in these type of patients, supplementing testosterone gonna help them feel better, have more energy, start exercising more, right?
Yeah,
So,
and it's a loop. If everybody thinks about it, the more exercise you do, the more testosterone you will have. And especially if you have a replacement, now you have a double whammy in which the man feels obviously that he is gaining control
right.
over the way he was feeling and his symptoms. What an interesting topic. I'm sure that you have a whole bunch of men storming into your office for help. But again, this is part of prevention. And to all the students on the call, this is something that you must keep in mind when you start treating men and looking into exactly what their levels are and how to prevent those potential conditions that could be detrimental for the patient. Dr. Valdes, we can have you here for quite some time because this is a really interesting topic, but we are already done with the half an hour that we allocated. And I would like to thank you once again for accepting our invitation and coming to talk to us about this important treatment. And to all of you for participating, for your questions, thank you so much. And please feel free to email us at BHIWebinars@baptisthealth.net. Should you have additional questions for Dr. Valdes, we will make sure to forward those questions to him in order for him to respond, and we will send them back to you, of course. We look forward to seeing you all the next quarterly medical lecture scheduled for Wednesday, November 17th of 2021, of course. Thank you once again. Stay safe and have a great afternoon. Thank you so much, Dr. Valdes, for all
Thank you very much.
your information. Thank you.
Bye.